Lynette, are you good? Is it working?
Yep, I think I'm good.
All right. Well, it's 4 o'clock and Dr. Lukowitz is running a little bit late. So he did ask me to, if I would start the meeting. And of course, this is the subcommittee of the Children and Adolescents of the Behavioral Health Reform Commission. And we're going to start the meeting today with Commissioner Newgle, Commissioner of the DCH, and welcome, Commissioner, and I'll turn it over to you.
Thank you. And I just have a couple of brief remarks. Lynette Rhodes obviously is with us and our Medicaid expert and the director of that division, and I'll let her walk you through the bulk of what we wanted to share with you today, which is kind of an overview of how Medicaid plays a role in this space. But I think you'll also hear later from Bhavini Solinsky from AmeriGroup, one of our partners, and hear a little bit about some of the newer work that is going on in this space that we're proud to have partnered with on them. And I hope you find it as exciting as I do. We're also working on some future projects and some bigger things that I think will continue to impact this space in the coming weeks, but more likely coming months. Lynette has shared with me that we're currently working on a project with the Department of Behavioral Health and Developmental Disabilities on some grant funding they received to further expand behavioral health services that are available at at some of our community service boards under grants that they're receiving from SAMHSA. So we look forward to continuing working with them and moving that effort forward. As well as we all know, we have a number of rate studies related to behavioral health providers that are due back, I think, in December, and we're on track to deliver those. As we simultaneously continue to work on the overall healthcare landscape and how I just mentioned to the previous subcommittee, I think we've been present at all three today, on some of the other work that we're doing around supplemental payments, most recently still pending some within the hospital system and our physicians. And I just lost everyone. Oh, that may be me. So I'm going to pause there. I'm happy to take questions later today or circle back up, but I'm going to turn it over to Lynette if you guys can still hear me.
Yep, we can.
We can.
Can you all hear me clearly?
Yes.
Okay. Hi, good afternoon. Again, I'm Lynette Rhodes, Executive Director with the Medical Assistance Plans Division. I see some familiar faces. Mr. McGibney and I worked together a few years ago on a project for school nursing services, which, by the way, we did get stood up and implemented. And of course, Gwen, we know Gwen from our PRTFs, and actually had the opportunity to go out and visit with her and her team. Wow, maybe a little over a year ago, Gwen. It's been a minute, but I'll go ahead and kick off. So we're going to just present kind of high level today on, as Commissioner Noggle stated, some of the things that we're working on here at the department and the services that we provide today. So I'll start off by talking high level about how we're set up at the department. So as everyone knows, we are the single state agency that administers the Medicaid and CHIP programs. We operate under two service delivery models. One is fee for service and the other is managed care. And so in terms of fee for service, our aged, blind, and disabled members receive services under the fee for service model, as well as our waiver recipients. And so these are our individuals who receive services, home and community-based services through our 1915C waivers, and then also our GAP members, which are our children who are enrolled in the Georgia Pediatric Program that provides skilled nursing services. So that group of individuals are in fee for service, and the others are in managed care. So our low income families, our Peach Care for Kids members, our newborns, our children under 19, our pregnant moms are all in managed care. And as you know, we have three care management entities in Georgia: AmeriGroup, CareSource, and Peach State Health Plan. And they administer the Georgia Families Program for the state of Georgia. Additionally, AmeriGroup administers the Georgia Families 360 program, and that program provides services to our foster care, adoption assistance, and DJJ populations. And of course, the last bullet I have here just indicates that within broad federal guidelines, we determine the range of services, payment levels, operating procedures, et cetera. Although we serve as the single state agency, we do not do this work alone. I will tell you, we work very closely with our sister agencies, and I've listed them here for you. Department of Juvenile Justice, Department of Early Care and Learning and Development, DFACS, who does our eligibility determinations on our behalf, the Department of Behavioral Health and Developmental Disabilities. As you know, they play a major role in terms of behavioral health and mental health services in Georgia. They are the Behavioral Health Authority for the state of Georgia. So we do work very, very closely with DBHGD. Of course, the Department of Public Health, they provide services through many of the county public health departments. And then the Department of Education, we work closely with them as well. A few years ago, we implemented or expanded the scope of nursing services provided in the school system. And today we're working on a project to provide them with some Medicaid data so that they can identify those Medicaid children who would be eligible for free and reduced lunch. And while not necessarily related to behavioral health, it's definitely related to the social determinants of health and as a means of addressing them. On this slide here, I've outlined for you just the fact that the scope of services that we provide in the Medicaid and CHIP programs are outlined in our state plan. And that is a comprehensive document. We consider it to be our contract with CMS. And so they have to approve the state plan and they have to approve any amendments to that state plan. And through that state plan, we have to give assurances to CMS that we are complying with federal law. So there are 2 state plans in the state of Georgia. There's one for Medicaid and there is one for CHIP, which is also our Peach Care for Kids program. Just wanted to point out to the committee the fact that we do work to ensure we're complying with the Mental Health Parity and Addiction Equity Act. And so for those of you who may not be familiar with this legislation, it in essence prohibits any type of discriminatory practices that limit coverage for behavioral health treatment and services. And it requires that as it relates to mental health and substance use disorder services, they can be no more restrictive than the coverage that we provide for traditional physical health, medical, and surgical procedures. And so the provisions of the Parity Act apply to our managed care organizations and to CHIP. So we are required to comply with those provisions. And in order to do so, we receive reports from our care management organizations, which help us to ensure that we are meeting those provisions. Here I listed for you, just at a high level, some of the expenditures for state fiscal year 2022. There's one slide here for Peach Care for Kids. The next one is for the Medicaid program. And as you guys know, state fiscal year 2022 closed out on June 30th of 2022, so just a couple of months ago. But here we identify for you the fact that our Peach Care for Kids children, for the most part, are receiving services through our managed care entities. So I've identified for you here the amount that we paid in capitation payments, which is $405 million for the Peach Care for Kids population. And then for these areas that you see here, the different colors, the dark green, the light green, and the red, those represent the amounts that we've paid on the fee-for-service side of the house. So we do have some children who are Peach Care for Kids members who are in fee-for-service because they are deemed disabled by the Social Security Administration. Here we've identified for you the expenditures that we spent during state fiscal year 2022 for Medicaid. And it's a little different picture here, right? So you can see from this particular slide that we have several members who are in fee-for-service, and of course, those who are in managed care. You know, what we've always noticed about the Medicaid program is that while the majority of our members are in managed care, the majority of the costs are on the fee-for-service side of the house. And that has been the trend for many, many years. And so while the ABD population is very small, and today it's a little over 600,000 members who are in our fee-for-service program, they are the most costly. But the ABD population also includes some children who are enrolled in Medicaid, again, who are deemed either disabled or they may be receiving services through our Georgia pediatric program. So again, just outlining here for you at a high level, the expenditures for state fiscal year 2022. And as you can see in the top right-hand corner, there's a dark blue shade that represents how much we've spent for mental health services. And that's on the fee-for-service side of the house. So just thought you'd be interested in seeing that. And just for your general awareness, we now, as of September 30th, enroll 2.7 million members. Again, 2.7 million members. And of that amount, 2.1 million are enrolled with our managed care plans. And again, the other 600,000 are in fee-for-service. I want to shift and start kind of delving into the services that we provide as it relates to behavioral health and mental health services. And so my starting point, particularly as it relates to persons under the age of 21, is always the EPSDT provisions. So these are our early and periodic screening, diagnostic, and treatment services, also known as EPSDT. And so these are the screening services that we are required to provide by federal law. And so the screening services include things like vision, dental, hearing, but also mental health, developmental health. And so those are the types of services that we look at. As you can see from this screen here, it tells you that as it relates to screening services, if you look at B as in boy, it says those screening services shall at a minimum include a comprehensive health and developmental history, including assessment of both physical and mental health development. And so all of our managed care entities are responsible for providing these EPSDT benefit services. We're also required to provide them on the fee-for-service side of the house. And here we've just listed out for you again the typical EPSDT services, but I wanted to highlight for you paragraph number 5, which I think is the most critical part as it relates to EPSDT. And paragraph 5 tells you that not only are you required to do the typical screening services, but we're also required to provide any other necessary healthcare, diagnostic, and treatment services that will correct or ameliorate any defects, physical and mental illnesses discovered by those screening services, whether or not such services are covered under the state plan. And that's critical. And so what that means is it allows us to stretch or to expand, and when necessary, to go outside of the scope of services that are included within our state plan, which we talked about just a moment ago. And when we talk about correcting or ameliorating defects, what that means is that what services can we provide that are going to correct or reverse the condition? Or when we talk about ameliorate, that means to maintain. So how do we either correct or reverse or maintain the child's condition? And, do we do that under the traditional scope of services that are provided under the state plan? or in some instances, do we expand and go beyond that? So that's the critical takeaway that I wanted to share with this group here. We are required to do annual EPSDT reporting, and that's through our CMS 416 report. And here it identifies for you those particular items that we track. So the number of children provided screening services, the number of children referred for corrective treatment, the number of children receiving dental services. So I want to say maybe a year and a half ago, we changed how we handled the reporting. And so CMS is now doing the reporting on behalf of the state of Georgia, and not just Georgia, but many other states. And so CMS is pulling the data, they're compiling it and doing all of the data analytics, and then they are reporting out on where we stand as it relates to EPSDT services. And those reports are available publicly. All right, let's see. Can you guys still hear me? Can you all still hear me?
Yes.
Yes.
Okay. All right. Just want to make sure. We also have a new service, fairly new service that was implemented back in 2018. And this is our autism spectrum disorder service. And so I can tell you, prior to 2018, there was a huge demand for autism spectrum services and ABA therapy services. So we were able to get funding to implement this new service, and we did get approval from CMS in 2018. So we amended our state plan and added this as a new service. So autism spectrum services are available for individuals under the age of 21. The ASD benefit includes an assessment, a treatment plan, and services, and prior authorization is required for all services. Here we've listed for you the diagnosis codes. So in order to be eligible to receive autism services, you do have to have one of the diagnoses that are listed here on the screen. So Asperger's syndrome, autistic disorder, Rett syndrome, one of these particular diagnoses must be identified prior to the receipt of those services. The next area that I wanted to talk about was CIS and CISS. And so these are our children intervention services and the children's intervention school services. And so they're pretty much the same. It's just the differences in where the services are provided. Children's intervention services are provided in the home and community-based setting, and the children's intervention school services are provided in the school system. But it's the same services. And so there are 7 therapeutic services that we provide. It's audiology, it's nutrition services, physical therapy, occupational therapy, speech therapy, and counseling. So those are the services that are provided. And so I highlighted for you here what we look at in terms of counseling as it relates to behavioral health and mental health services. So for the counseling services, we evaluate social, mental, cognitive, emotional, and behavioral health problems. So this is all a component of the CIS and CISS programs that we provide that are available to children. We also have community behavioral health rehabilitation services. And so these are services that are provided by outpatient mental health centers to persons ages 4 and older, as noted here, who are emotionally or mentally disturbed or have substance use abuse disorders. And so there are several services that fall under the community rehab benefit. And so I've just highlighted some of them for you here. The ones that are highlighted in red are definitely areas where there is a high demand. So when you're talking about crisis intervention services, crisis stabilization services, That comes into play when you have a child who has basically reached a point where they can no longer be maintained in the community. And I know Gwen Skinner, you being a part of this committee and basically serving with the PRTF, are very familiar with these types of issues. And so in many instances, we try to send children to a crisis stabilization unit in order to stabilize their behavior. So it is a short-term solution that is available. And the hope is that we'll be able to stabilize that child and return them back to the community setting without having to be admitted to a PRTF. And of course, the behavioral health assessments. We also provide through this particular rehab option several services that are listed here: addictive diseases support services, intensive family intervention, family outpatient group, medication administration, which is critical, as well as the other services listed here. Then we also have intensive customized care coordination, IC3. And so that's a very intensive high level of care coordination that's provided to our members. And that typically is provided to them when they're in the community setting, but that should begin before, typically before they are discharged from a PRTF. Of course, psychosocial rehabilitation and peer supports. So these are the listings of all of the services that we provide through the community behavioral health rehab option. So several services there. Next, we also provide to children with behavioral health and mental health issues services provided in a psychiatric residential treatment facility. So in the state of Georgia, we have 6 PRTFs. And this is an inpatient level of care that is provided in a residential facility rather than a hospital. And this is also intended to be a short-term intensive treatment program that provides medically necessary treatment to our members. I think before I started with the presentation, I shared with the group that we had done last year, just a year ago, a little over a year ago, a tour of all of the PRTFs within the state of Georgia. We did visited some of those facilities with Commissioner Noggle. And it was very insightful because we got a much better understanding of the different models that each of the PRTFs offer. And so they're not all the same. They're different in terms of the services that they provide, their arrangements, their setups, the various levels of acuity, because those members do have different levels of acuity that they present with. You have some that are very high needs individuals that require one-on-one supervision. And then you have others who may be able, to be with a group of other kids and maybe, under the supervision of multiple individuals. The PRTFs also provide OT, PT, ST, individual, family, and group therapies. And then we work with the PRTFs in terms of discharge planning, because one critical component is that before that child leaves that PRTF, we need to ensure that we have services available in the community, already established, already set up for when that child returns home to the community, hopefully back to their families. So the PRTFs, while definitely a critical component of the services that we provide to children, it is not intended to be a long-term solution, but intended to be short-term. We will be implementing very soon, and I'm excited about this, a new service within our state plan. And this is going to be called Behavioral Support Services. And so the way that this will work is it's going to be similar to our GAP program. So for those of you who are not familiar with GAP, that's our Georgia Pediatric Program. And through that program, we provide in-home skilled nursing supports, as well as in-home personal support services provided by a certified nursing assistant. And so this will mirror that type of setup. So we will send into the home, into that member's home, a behavioral support aide. And that aide will be there to basically assess and hopefully help that child to maintain their status. And when they see that that child is escalating, that their behaviors are escalating, be able to address those in home with the family, with the child, and hopefully prevent any PRTF admissions or admissions to a crisis stabilization unit. So these services will be provided in block hours, meaning that that aide could potentially be in the home for 4 hours a day, 5 hours a day, 6 hours a day, or whatever is deemed medically necessary. So these services will be available through prior authorization. They can be utilized as an individual service or part of a larger package of services. And what we're looking to ultimately implement is a therapeutic care model, which will provide basically a package of services, and behavioral support services will be included within that package. But again, this is something that we're working on now with CMS, and we're actively collaborating with both DBHDD and DFACS on implementing this particular services. And so it does include the initial behavioral assessment, again, any behavioral interventions, and an assessment of the success of the intervention. So we'll keep you posted, but hopefully we'll have this stood up very soon. The next thing I wanted to mention, and Commissioner Noggle touched on this in her introductory remarks, and that is the Certified Community Behavioral Health Centers. So this is also a new service that we're working very closely with DBHDD to implement. And so SAMHSA awarded grants to 11 facilities in the state of Georgia. And these grants were just awarded in September of this year, so just last month. And these were $1 million grants in order for them to build out their services. And so this is specifically designed to address individuals with co-occurring diagnoses. So individuals who may have autism with a co-occurring diagnosis. And the majority of the 11 provider agencies that were selected are community service boards, which are absolutely equipped to provide this service today. So I've listed for you here the goal, which is to provide comprehensive, integrated, coordinated, person-centered behavioral services. And this is going to include 24/7 crisis services. And this can be provided to any person with a mental health or substance use disorder, or someone with serious mental illness. It's available for children and adolescents with serious emotional disturbances, as well as adults. And so these entities will have to be certified by the Department of Behavioral Health and Developmental Disabilities. And once they receive that certification, they will then be eligible to receive enhanced funding. And so I've listed for you here the 9 core services that these facilities will be required to provide once they get certified. So of course, the crisis mental health services, which includes 24-hour mobile crisis teams, the screening, assessment, and diagnosis, patient-centered treatment planning, outpatient mental health and substance use services, outpatient clinic primary care screening, case management, psychiatric rehab services, peer supports, and of course, community-based mental health care. So this is something that we're working very closely on now with DBHDD. We plan to present this to CMS at the beginning of calendar year 2023. So we're working now on the state plan amendment and how that will look. And so, of course, we'll have to get permission from CMS to move forward, but just wanted you to be aware that this is another opportunity for us to expand the scope of services that we provide in the behavioral health space, particularly as it relates to children and adolescents.
So Lynette,
Yes.
are the crisis response teams, are the mobile crisis teams,
Mhm.
are those in addition to what the department currently contracts for now, or would they utilize what they have in place and just?
Yep, good question. The goal is that it be in addition to. Now, I'm sure that, you know, there will be some collaboration and sharing of resources, particularly in the beginning, right? When this first gets stood up. But the goal is that this be in addition to, so that we can expand the scope of services.
And
And
then,
Lynette, you said this was from a grant. Did you say federal grant?
Yes, so SAMHSA issued this grant. They did a notice of funding opportunity back in May of this year. And so, of course, you had to apply for the funding, but they did the notice of intent to award, I think, back in June or July, and those grants were issued in September. So yes, this was a funding opportunity.
So the sustainability would be on the billing end?
Yes. So we'll, of course, have to get funding to be able to keep this going forward. And we'll need the support from OPB. And keep in mind, DBHDD pays the state share for these services. So they will be funding the state share, and then we will draw down the federal match for these services. But yes, sustainability will be a big component of this.
And I would think that, I mean, this sounds great. I would hope that the goal would be for all CSBs to at some point be involved in these centers.
You know, I think we'll get there. You know, for the 11 that were selected and that received the grant funding, you know, they're getting stood up now. We think there will be other grants awarded in the future, because this is actually the second round of grants that SAMHSA has awarded for the CCBHCs. So we think there may be other grants awarded in the upcoming years, and then hopefully the other CSBs can get on board. And I will mention this to that point. Of the 11 that received of the 11 facilities, 9 of them received the SAMHSA grant. 2 of them received funding from appropriations that were provided in this year's appropriations bill. So there may be a combination of grant funding and appropriations moving forward. So we'll see how it works.
one last question, so I don't keep interrupting.
No, you're good.
Is when you talked about the new service, the behavior supports.
Yep.
What would be the requirements for someone to provide that service? Are you looking at behavior techs, or what? Who are you thinking? What level?
Yeah, so we're thinking a couple of things on this. So one is, can we utilize the RBTs that provide autism services today? Because we have had some cases, Gwen, where we've placed an RBT in the home of a member to assist with their behavioral issues. So we're hoping to be able to utilize RBTs and expand that network, but also techs. And we're also looking, Gwen, to see if we can do what we're calling kind of a combo, meaning a behavioral aid and a personal support aid in the home together. Because you'll have some members who, while they have behavioral health needs, they also need assistance with the activities of daily living. And so we think it would be a good combo to have them both available to provide services.
Okay.
Ms. Rhodes, I'd like to ask the question, please.
Yes.
So I wanted to ask about the addictive disease services. Where are those services available?
So when you say where, are you asking about
Across the state?
Yeah, they're available statewide. So all of these are available.
Are they part of the community service boards?
I'm not certain if they're a part of the CSBs. I can confirm that and send you a response via email, but they're available statewide.
Okay,
And I want to go
Yeah, I
back.
would appreciate that.
Are you speaking of like the residential programs or the outpatient programs?
Well, I mean, I just see, she called it addictive diseases support services. That was sort of not, it's not specified.
Okay.
So I was curious about that, and
Yep.
I just wasn't sure exactly how to direct patients to access those services.
Got it. Got it. So what I will do after this presentation and our meeting today, I'll send out to this group the summary of those services that are outlined in the state plan and where they can be accessed.
And I want to apologize to Commissioner Noggle for my my tardiness. Unfortunately, it's not a reflection of my placing lower value on her speech. I just was unavoidably detained. So I appreciate your presentation, and I'll let you continue.
Yep. All right. So the other things that I just wanted to mention is that while we provide behavioral health services to children and adolescents, and the fact that most of those individuals are enrolled in our managed care entities, we also look at the quality measures. And so I pulled out and wanted to share with this group here just some of those measures and metrics that are focused on children and adolescents. So of course, and this is just a few: developmental screening in the first 3 years of life. And these are measures that we're looking at for Peach Care for Kids. So these are specific to the Peach Care for Kids population. And this is what we'll be looking at for state fiscal year 2023, which just began on July 1 of this year. So these are in effect now. So as we get towards the various, measuring marks each quarter, then we will be receiving data from our care management organizations, and we'll be able to report out on where we stand. So follow-up after emergency department visit for mental illnesses for children ages 6 through 17. Follow-up visits after ED visits for alcohol and other drug abuse or dependencies for ages 3 to 17. Follow-up care for children prescribed ADHD medication. So again, these are just a few of the quality measures that we'll be looking at during this fiscal year. For our Georgia Families 360 program, which is for our adoption assistance, foster care, and DJJ population, I listed a few of those measures here. So again, well child visits in the first 30 months of life, developmental screenings in the first 3 years of life. We'll be looking at the percentage of youth readmitted to a behavioral health facility or an acute care facility within 30 days of discharge. And so this is definitely an area of concern for us when we have children who are discharged from these entities and then 30 days later, are readmitted. And so we want to look closely at that and identify the causes for that, as well as what do we do to prevent that from occurring. And then, of course, use of multiple concurrent antipsychotics in children and adolescents. And then for the regular Georgia Families program, we have the set of measures that are listed here. And so some of the same that I mentioned earlier: child and adolescent well care visits, screening for depression and follow-up, and adherence to antipsychotic medications for individuals with schizophrenia. So these are all of the measures that we'll be looking at for this fiscal year. So that concludes the presentation. I know I had a limited amount of time today. The one other thing that I wanted to mention to this group, and I know there have been a couple of presentations on this previously, and that relates to geo-access and network adequacy. And so we do measure and track that with all of our care management organizations. And so we are able to see from those reports where services are available statewide. So the way that works on our end is we will, for example, look at all of the psychiatrists across the state of Georgia. So we're able to identify on a county basis how many psychiatrists are in the state of Georgia in each county. We're able to identify where those psychiatrists are located. We're also able to identify the number of members, the number of Medicaid and CHIP members within those counties. where those members reside and what distance they are from those particular facilities or practitioners. And from there, we can determine the number of members that have access versus the number of members that do not have access. And we can also see, if there aren't services available within that county, how do we map them to the next nearest provider, even if that provider is in, the next neighboring county. So we do look at geo-access, and I wanted to mention that to the group today because I know there have been some presentations on that previously. So with that stated, I'll pause for any questions from the committee.
On that point, Lynette, would that data include which clients those psychiatrists serve, whether they serve children or a certain age group?
So that would not be included in those geo-access reports. However, that data is available from a provider enrollment standpoint. So from a provider enrollment standpoint, we're able to determine, if that provider is accepting new patients, whether or not they are treating children or adolescents. And we're able to identify a lot of this through what we call secret shopper calls and through our auditing process. So we actually call providers. We do this on a regular basis, and we call them under the guise of being a member. So we'll call and say, hi, I'm a member. I want to schedule an appointment. So we're able to determine how long is it going to take us to get an appointment? Is it a week? Is it 2 weeks? What is the waiting list? What's the wait time? Are they accepting new patients? Because they'll tell you when you call, well, we're not accepting new patients right now, or we're full. And so we're able to confirm all of that. Is the office actually open? Is the provider still at that location? So we're able to identify all of those things through our secret shopper process and some of those metrics through the geo-access network reports.
So you can cross-match the geo-access data with that data?
Yes. Okay. And we do that here at the department, and the CMOs do the exact same thing on their end. So we're able to see, statewide across the board, what's happening with the network.
So are you also tracking the children that are placed out of state due to lack of capacity?
Yes.
in residential treatment programs due to lack of capacity in state? It continues to, it's almost like someone has to stop the madness, because we've got half of our beds are gone to other states. Our kids are leaving here because we don't have them, going to other states.
Yeah.
And I think some state has got to take a problem-solving role to that. You can't just stop doing it because children need treatment. But what is it that's causing that to happen? And is there someone here who could develop that capacity?
Yeah, I can speak to some of that, Gwen, and I think probably Bhavini could speak to some of that as well. The kids that we typically send out of state, and we try very, very hard not to send kids out of state for a number of reasons. Number one, once they're out of state, it's just very difficult to keep that that connection between the member and the family, right? And particularly if we have to send them, far away across multiple state lines. And so, that's a major area of concern for us. But to answer the question directly, what I have found and what I have observed is that the children who we send out of state are the kids that have the highest level of acuity and that they have co-occurring diagnoses. The ones that are mostly going out of state are children who will have a diagnosis of autism and ADHD, or autism and, oppositional defiant disorder and some type of developmental disability. They're co-occurring diagnoses. Their acuity level is very, very high, and their IQ may be very, very low. And where that becomes an issue in the state of Georgia, and I touched on this a little bit as I talked about the PRTFs, because their models are all different. So the 6 PRTFs that we have in Georgia, they have different models. They are not all equipped to handle a child who has a very, very high acuity level, who needs one-on-one supervision. And I think that's where some of the issue comes in, right? Because you only have a certain amount of staff. There's only a certain amount of capacity in rooms and beds available. And so the issue becomes, can this PRTF take one person from their staff and have this one person that's assigned to be with this child, basically 24/7, are they able to do that? Number 2, are they set up to be able to care for a child that has that very high acuity level? And some of the behaviors of some of the children, they're extreme, to the point where I think the one of the concerns expressed by some of the PRTFs is it's one thing for a child to have and exhibit self-harming behaviors, right? Where they're doing harm to themselves. It's a different situation when they're harming others. And is that PRTF equipped to be able to prevent that child from harming not only themselves, but doing harm to other children in the facility? And so what I have observed are that the kids who we are sending out of state fall in that category, and they're just very hard to place. And Gwen, I don't know if that's what you're seeing, but that's been my observation.
They are very complex.
Yeah.
They are very complex cases, which is not to say that we couldn't develop it
Right.
in Georgia, because I think that we do have good qualified providers in Georgia. It's just getting our arms around it and looking at what we purchased on behalf of children.
Yep.
And could we take that same amount of money and purchase something? Because again, a lot of times it's one child who has very unique treatment needs.
Mm-hmm.
There's not like an existing program to meet those needs. So you have to go to a state that has that treatment program. I think it's something we need to attend to, because I don't think that any state is kind of stopping the madness and saying, we're going to address this a different way.
Yeah, I participate on the calls with the National Association for Medicaid Directors, and particularly those who are in the South region. So, Georgia, Florida, Texas, South Carolina, and Louisiana. And you find that it's the same concern across all of the states. And so I think we're all struggling to find a solution, but you're right. We really just need to sit down and kind of hammer out, what does the model look like for these children? And one area where, I would like to explore more is room and board. And so for the Medicaid program, we can't pay for room and board. And I think that is a huge barrier for us. Because it prohibits us in a lot of ways, but it's what the federal regulations require. And so I do think on some level that needs to be revisited with CMS and Congress in terms of, opening up more capacity, because that could be, a key, but that's a bigger discussion, but just kind of some of my thoughts that I've had.
Yeah.
I'm concerned that a lot of those really difficult patients are patients with autism and intellectual disabilities, and that really creates some major challenges. And to up our game a little bit with that population would be intensely helpful.
Yeah, I agree. I think we've seen it enough times. I've seen it enough times to know that really is I think the area where we struggle the most. And having to send those kids out of state it's just challenging and something that we really try, not to do if we can. But unfortunately, there are those instances and those very complex cases that Gwen mentioned where we just have to send them out of state.
And every out-of-state placement is not necessarily farther away from the family. We all know that Youth Villages has a program very close to the North Georgia border. So sometimes it's actually closer for the family.
Yep.
Devereaux has Florida. Sometimes
Florida, that's right.
live in extreme South Georgia. It makes sense for the family to do that. But I do think it's something that our state needs to maybe be a little more progressive than I've seen any other state be. Dealing with it.
Lynette, I don't know if you recall, but we did a little bit of research on the actual number of kids that we sent out of state over the last 4 or 5 years, at least on the fee-for-service side. I don't know if you want to speak to that a little bit.
Yeah, it was actually pretty small. So it's not like it's a significant number of kids. It's literally, in the 20s. It's a small, tiny subset of kids that we're sending out of state. So, that's a good thing, right? Which means the majority of them are able to be placed within the state of Georgia. But even for those that we send out of state, it's just challenging to get them back home. It just becomes challenging. And, hearing some of these families talk, and you just have to talk to the families, it's heartbreaking, right? Because they have other children at home that they're concerned about. And where it really kind of, where the rubber meets the road is, that family has to say, can I really manage this child at home? So, Bhavini, I'm sorry, I've taken up like a whole lot of time. But good questions.
Well, thank you so much. This has been very enlightening, as all of our speakers have been. So I appreciate your doing this for us today.
Yep.
Without further ado, I want to introduce my friend Bhavini Solanki, who's Director of Behavioral Health at AmeriGroup. And Bhavini, all yours.
Thank you. And no need to apologize, Lynette. That was such great discussion, and so needed. And we've talked about it in so many different arenas that we've really just got to get our providers to a place to really meet the acuity of our members, because it's not the same as it used to be, and certainly not as same as when I was out in the field. So definitely excited to be a part of that discussion. So good afternoon, everybody. My name is Bhavini Solanki, and I serve as the AmeriGroup Georgia's Georgia Family 360 Director. I previously served as the Health Plan's Behavioral Health Director and an LPC, and have started my career in Georgia working with kids in foster care. So this population is very near and dear to my heart. And I know we're not supposed to say work is personal, but it's personal. So excited to be able to come and chat with all of you. I'm glad Lynette did all the hard work for me to talk about all the services we already provide as managed care, because I get to come and chat with you a little bit about things that we're doing that are above and beyond. So I wanted to start today and just share a little bit with you about our Georgia Family 360 vision and mission statements, just so that, again, like I said, this is true to my heart, and wanted y'all to see that it is really true to everybody on my team's heart, as well as our health plan. So the 360 vision is to have healthy members in a new and ever-changing world. And we really liked this vision statement, given the world of COVID that we're in and the unknown that really is the territory we're in right now, right? But our mission in an effort to accomplish that vision is to improve the health of our members through advocacy efforts, accountability, care coordination, training, high quality preventive care and treatment. And so hopefully you'll see from the presentation I'm going to share with you today how we are working on that path. So I'm excited to first share with you a digital solution that we have brought to light with a vendor partner called Gomo Health. specifically to address our autism spectrum disorder population. As Lynette talked about, it is a fairly new benefit for the state. And we, as a health plan, have been learning a lot over the last 4 years. And that's where this program really came to light. So with the work of GOMO, again, it's a digital solution. So outreaching caregivers through texting, or they can use a website if they choose to do that. And there are some one-way and some two-way conversations that occur. So there are two kind of levels to this program. I'll start with our first level, which is the early intervention component. So for all of our members who have a current diagnosis on the ASD spectrum, and this is across Georgia Families as well as our Georgia Family 360 membership. So I think we're at about 617,000 members. So across that whole range, we've got a little over 4,000 members with current diagnoses. Those caregivers were outreached, and our purpose with this component is really to, one, make sure that they know we're here for them. Although Georgia Family 360 is required to have a care coordinator assigned to every member, on the Georgia Family side, case management is an opt-in program. So they can choose to be a part of it, but they don't have to, even if they're considered kind of high risk and could really benefit from it. So this is kind of a supplementary program that allows us to extend our care coordination concierge program in a way that's maybe a little more palatable for some people and some caregivers who are busy. So in this first component, there's outreaches that go out to these families, asking how they're doing, how their child is doing. Are they in services? Do they need resources? Are the services beneficial, or is there something we need to help them change up? There are also escalations that are built in as they answer to different questions. If they answer in a certain way, they don't necessarily know this is happening, but it triggers our case manager to then outreach them. For example, if they express that they are having difficulty with transportation to get to a service or an appointment, then that would trigger our case management to help get them set up with NEMT or other transportation offerings through Medicaid. Another plus with this program is the additional support tracks that caregivers can enroll themselves into just based on whatever they identify are their needs. So some of the tracks that we've got, you can see on the screen, are caregiver stress, educational support for their child, needing help in activities of daily living, or just general support for their attending to their child. We also have a specific tracks for adults that are diagnosed with ASD, so the 18 to 21-year-olds. Through some of the supportive tracks, you can see the amount of escalations we've been able to engage in. And these numbers are even a month old. This program started in the middle of June, so this has grown even more from that. But caregivers that have expressed that they're feeling a significant amount of stress so that we can then give them the additional support that they need. Caregivers that are feeling a lack of confidence, and then just reported concerns over their child's well-being. I've been really excited about the bottom on the left, where caregivers have identified having crisis event in their home in the last 3 months. You know, our claims data can show when a member goes to the emergency room or to an inpatient facility, but families also describe crisis in different ways that don't equate to a claim, right? And these are events that we really want to get in and start working on them with ahead of time so that they don't have to go to the emergency room unnecessarily. And then you can also see the variety of ways we've been able to give them the care that they needed, like giving them access to community resources and then really enrolling them in that ADL track to get them those additional supports. So our second level of this program is an early detection track. So this is for caregivers of members who are age 0 to 4. And this is, again, to get them in there early, to get them to understand that you're on a track for EPSDT visits. Do you know about that? Do you have a PCP or a pediatrician for your child? Do you have any issues getting your child to this appointment? Here's the appointment that the ASD screening occurs at. Here's what the screening means. Here's what it's going to look like. Here's what you're going to expect. Here's what to do with the results that come from that. And here's how we can help you with whatever the results might be. So we've been able to enroll almost 58,000 caregivers into that program, just to give them all of this necessary information. And as of last month, we had several that were indicating to us their challenges with getting their child to that well child visit, as well as caregivers that were needing follow-up from those visits. So in the couple of months this program has been active, we've been receiving really great retention rates, really great allowance for us to escalate some situations and get care to these families sooner than later. The next phase of this program is going to be, we're in discussions with some BCBAs and some pediatricians to try to figure out what information we can share with them for their relevant members from all this information that we're collecting. So really excited about that and hope to be able to come back and share that update with all of you soon. So the next piece I wanted to share with you about is a predictive analytic tool, and this is what Commissioner Noggle was referencing earlier. We were really excited to showcase this to DCH and DFACS. We know that the hoteling of children in foster care is an issue around the nation and not a setting that we want any child to be in. Unfortunately, with the lack of or the reduced number of placement options, it is a challenge that we're all faced with. So we really sat down as a company to try and think about how can we address this in a proactive way. So we put together all of the data that we have from our current authorizations, utilizations, information that we get from caregivers when they're outreaching to our member intake lines, as well as historical data we get from DCH when members come into eligibility, and put together a machine learning model that really helps us from the time that members become eligible to understand which members are at the highest risk for a hoteling stay or potentially an unnecessary PRTF. And this is information that we've already started utilizing in our triage team, which I'll tell you about a little bit in just a second. But so that we can get them into the right level of case management ahead of time. DFACS can also intervene ahead of time, and we can get services attached to this member earlier, and again, hopefully try to avoid some unnecessary movements. So I wanted to give you a little bit of a case illustration just to kind of visualize what we're hoping to accomplish with this and other tools. So let's say we have Alex, who is in foster care, came into foster care last year. She's 15 years old and lives in Atlanta. When she first came into care, she was placed in a temporary foster home, as is typical for when a child comes into care. But within her first 30 days, she had already disrupted this placement and had subsequent CSU or inpatient stays. In our current state, before we had this tool and before we kind of moved to this triage team, all of our newly eligible Georgia family members would move into what we call an emerging level of care, which is the lowest level of care, as we don't have a lot of information about what's going on with these members. And it's not until they really go inpatient or go into an emergency room that we know to escalate them, or we're notified from DFACS that something's happened with their placement, and we escalate them into the next level of case management. As you can imagine, this is very reactive, right? It doesn't give us any time to be proactive and to get services in place before any additional higher level of care is needed. So with the implementation of our triage team and this tool, we would be able to assess that this member is at high risk. Let's go ahead and get her into complex level of case management. That case manager can then link her to an IFE provider in her area or a comparable level of care, because I know IFE is not available everywhere. And that provider can really start establishing that relationship with foster parent and foster child and really build that therapeutic relationship through treatment. So there's definitely other areas that this tool can help us influence. You can see the bar chart there. It's really just for illustration, but it will help us try to reduce unnecessary inpatient admissions, will help us increase necessary outpatient utilization, and allows us to really get member and family to be able to lean on their provider a little bit more. So to share a little bit about our triage team, this is going to be a group that really gets into place right after a member becomes eligible with Georgia Family 360. It allows us to conduct internal and collect external assessments to really, again, place this member in the correct level of case management and then get them the most necessary services at that time. It is also information that we'll be able to utilize in our clinical rounds, which happen every day with our 2 behavioral health medical directors. So I wanted to kind of show you our org chart in a different way. So you'll see the eligibility team there in yellow. We really only hold the member for about 24 hours. And then that blue team holds on to that member to collect the necessary clinical information, again, with our own internal tools, as well as collecting those initial 10, 10, 15 medical, dental, trauma assessment, CCFA, to then place them either in the correct adoption case management levels in purple or the foster care / DJJ levels in orange. All of our case managers are also going to be shifting around into what we call regional pods. So they'll be moving into regional pods that are aligned with the DFACS region, so that each region at DFACS, DJJ, whomever needs to get a hold of us will know specifically which 4 or 5 members at Georgia Family 360 are their direct points of contact. So just another way that we're trying to make business easier to do with Georgia Family 360, as I know we're a large entity, and we want to continue to be able to liaise with all of our partners in an easy way. And that's all I have for you today.
So Bhavini,
Yes, ma'am.
I think what we have experienced with children that have been in hotels is many times the reason they have failed out of foster care or their home is because they're either aggressive, sexually inappropriate behavior, or they've run away so many times, that kind of thing, which doesn't necessarily mean you need a PRTF to address that. I just want to be very careful that people don't see PRTF as a negative. A PRTF may be the appropriate level of care or not.
Right.
And I just want to be sure that it's not like somehow we've done something wrong. If a child ends up in an intensive level of treatment, we may have done everything right for them.
Yes. No, definitely, Gwen. And I appreciate that point of clarity. We certainly do need this level of care, and there are kids that need it. And we just want to make sure that other levels of care are available to these members, right? As early as we can get it to them. Yes. Definitely.
I have to agree with Gwen. Never is placement in a mental health facility, whether it's acute, inpatient, or PRTF, is that meant to be punishment. And unfortunately, some parents threaten that, and I say, this isn't a punishment. This is to help you keep you safe or have you develop the coping skills that you need to go back home and be successful. So, I completely agree with what Gwen was saying.
So are they going to be as focused on discharge planning as making sure they get the right services up front?
Yes.
Are they also going to track on the children and make sure that appropriate discharge planning is done?
Yes.
Services are in place?
And we are working, Gwen, right now to kind of enhance our PDM program, which is that post-discharge management team, and adding some staff to that team. So hopefully you'll see that directly at your agency as well.
Okay.
Mhm.
I can't wait to hear feedback from patients' families about how the SCOMO
Yes.
process is going, because I want to hear some success stories. So I can't
Yes.
wait for that.
It's been great.
Are there any other questions for Bhavini? Well, again, hearing none, let's go ahead and move forward. It looks like our friend Anne, and let me try to pronounce. I usually do pretty good, so let me just find. Here we go. I read it right off. Di Girolamo, is that about right?
That was super close. Di Girolamo.
Girolamo. Thank you so much. Thank you for being here and being helping us with this process.
Oh, thank you for inviting us, and good afternoon, everyone. I am the Director of Behavioral Health at the Georgia Health Policy Center at Georgia State University, and also the Director of the Center of Excellence for Children's Behavioral Health, also in the Health Policy Center. And I'm joined by Layla Fitzgerald, who is with the Office of Children, Young Adults, and Families at the Department of Behavioral Health and Developmental Disabilities, a mouthful. And Layla is going to co-present with me and share with you all some more information around the Georgia APEX program. Okay. So what we want to talk about today is really focused on school-based mental health as a potential mechanism for increasing access to services and also promoting mental health awareness. Are you all seeing? Let me see if I can get rid of this block.
Yes.
Okay, is that better? Okay, so I want to start with the why. We know, and we've been having multiple discussions over the months, over the years, about how common mental health needs in children are. We know that 1 in 5 children has a diagnosable mental health disorder. 1 in 18 suffers from depression. In 2019, from the Georgia Student Health Survey, around 40,000 Georgia students reported attempting suicide. We also know that half of mental health disorders start by age 14, so they start earlier, and it's important to acknowledge and address that. We also know that children and youth are often unable to access needed mental health services, with around 50% of those who need services not receiving them. Some of the barriers include lack of access and transportation issues, financial constraints, mental health professional shortage areas, and mental health stigma. And I think school-based mental health, providing services within the schools, can help to address many of these barriers. So what are some of the implications of this? Untreated mental disorders can cause significant challenges for young people, particularly in the educational environment. And in school, students with mental disorders and mental health challenges have higher rates of a variety of things. These problems, if they're left unaddressed, can cause children and youth to struggle to succeed by impairing academic performance, possibly leading also to maladaptive behavioral patterns that can result in truancy, disciplinary action, and creating cumulative long-term detrimental effects. Behavior problems within the school setting can also negatively influence the learning of other students and overall school climate. So what are some of the benefits of having school-based mental health programs? School is really the time and the place where children spend most of their time during these years. Often school-based mental health programs are some of the only ways that students with mental health challenges are able to access mental health services. Teachers are often the first to notice that a child is struggling. If we can train teachers to be able to identify behavioral problems, they can act as a source of referral for students to receive these services, provide relief from symptoms earlier on rather than later, to be able to see some of these outcomes that you see here on this slide. So improved school attendance, academic performance, school climate, access to mental health services, a decrease in discipline referrals and hospitalizations, and disruptions within the classroom, and overall mental health stigma. So the approach to most school-based mental health programs really follows a three-tiered approach. And I want to emphasize the importance of, when at all possible, to be able to have all three tiers within the school setting, because each of these tiers really supports and relies on each other. So if you take a look at this bottom tier of universal prevention that affects 85 to 90% of students, involving all school staff, examples of those types of initiatives might be mental health first aid training, mental health awareness events, anti-bullying campaigns, also positive behavioral interventions and supports. And then if you look at this second tier of early intervention, which affects around 7 to 10% of the students, working with counselors, social workers within the schools, as well as mental health providers. These are youth who have potential risk factors that can develop into more serious mental health challenges. And so examples here can include group therapy, targeted screening, skills training like social skills training. And then we have the top of the pyramid, or the apex of the pyramid, where you have students who have more serious mental health challenges requiring more intensive intervention. Around 3 to 5% of those students working directly with mental health providers. And activities there can include individual therapy, crisis intervention, and behavioral assessment. I also want to share that there are several different types of models of service delivery for school-based mental health. So the first is where you have a therapist who is actually hired as an employee within the schools. And a good example here is in Dublin City Schools in Central Georgia. Therapists there are part of the school climate program. They provide individual therapy and are on call 24/7 for mental health crisis response. They've tripled the number of counselors after the pandemic, so students always have someone to talk to. They have something on their website called a Shamrock button that students and staff can access 24/7 and get help. And they have something called a Minute of Wellness video that they share each week to teach ways to cope in different situations. The second model is school-based health centers. So a school-based health center, this model of healthcare delivery can eliminate barriers such as transportation, accessibility, cost for children and families living in communities with little access to healthcare. In a school-based health center model, here you've got mental health that's integrated within that school-based health center, along with physical health, dental care, and some of those services. And so a great example here are the Whiteford schools in DeKalb County. They've got comprehensive care, including primary care, behavioral health, dental care, with a focus on prevention. And then this last model is really a partnership model among agencies within the community. So it is having community-based mental health providers embedded and strongly integrated within the schools. And so one of the great examples of this type of model is the Georgia Apex program. And so I'm going to turn it over now to Layla so that she can describe and provide you a little bit more information about this specific program.
Well, good afternoon, everyone. I am Layla Fitzgerald, Director of Community Programs from, I'll shorten it for you, DBHDD, Office of Children, Young Adults, and Families. It is a mouthful. And the Georgia Apex program is a program that is a school-based mental health program where we have provided funding to local mental health providers to partner with local schools and school districts to provide services to local students. We are a program that is clearly earmarked for children who fall under the uninsured or underinsured, or those with SSI Medicaid. We do not provide services to children with private insurance because of how DBHDD is funded. Next slide. As you can see, there are many stakeholders in this program that really are needed in order for this program to be successful as it has been in the last 8 years. First and foremost, it's us, DBHGD, as we are the providers that vet, the mental health providers that provide the services. Our second partners are our school districts, our local schools and school districts. And as you can see, I won't read the slide. There are several partners that play a huge role in this. One of the other partners that I like to mention is the Center of Excellence at the Georgia Health Policy Center at GSU, and they provide evaluation for our programming now. Like many other programs that Ann mentioned that are models, many of them are not being evaluated as extensively as the Georgia APEX program, and we are able to provide very intensive data, as I'll speak to here in a minute, on our program to show just how much our program has impact. Another one of our stakeholders is the Georgia Department of Education. Of course, we can't do this without partnering with them. When we have joined into a venture 2 years ago now, yes, 2 years, where I now serve as the mental health liaison for the Georgia Department of Education under the Office of Whole Child and Supports. So this program has really allowed us to try to seamlessly merge ourselves together to be able to provide services in-house, in real time to students who may have never received mental health services. Next slide. And our program has 3 programmatic goals. The first is to increase access to mental health services for children and youth. The second is to provide early detection of child and adolescent mental health needs. And the third is to strengthen that coordination between community-based mental health providers and local schools. I'd like to add a fourth to that one, as we really are a huge connection to families through this program, as we know that each child is connected to a family. So we have seen where interacting with that child has allowed us the door open to interact with the family and to get really in depth into some intensive training and interventions and awareness and education for families to understand what's happening with their children. Next slide, please. Again, we are small but mighty. We are covering a large amount of the state. We are in 6 regions, 129 counties, 147 school districts, and we are now serving 738 schools. I think that number just rose. I think I got an email today when we were adding in another school, as it's ever evolving. It's a growing program and everyone wants it in their schools. But as we all know, there is a huge workforce shortage, so we are not able to provide that. But we do what we can, where we can, and how far as we can. We are partnering now with, I think we're up to 42 tier 1 and tier 2 providers. We grew over the last couple of years through funding that came through Governor Deal and Governor Kemp. So you may hear individuals consider themselves Apex 1.0, 2.0, or 3.0. We are all Apex. It's just the way we were funded that we have to track that because of how funding came in. We track them in different plots. Next slide. As I was mentioning, the COE provides monthly infographics of us for the Georgia APEX program. Our providers input data into a Qualtrics, and the COE, the Center of Excellence at GSU under the Georgia Health Policy Center, provides us feedback from that data and provides us infographics and data reports on everything that is received, from how many children were served, types of services that were provided, the CMO that was charged. You can go into the top 3 diagnoses. Next slide, because it sort of correlates to it as well. But I won't go into detail with every line on here because these slides, I believe, will be shared with you, so you'll be able to look at it in depth. But this is just the type of information that we receive. We know every school that we are in. We have a list of our schools. So we are very in tune. I talk with our providers on a regular basis. We provide regular trainings and office hours and webinars to them to make sure that we are on the same page and the same accord of being able to support them from the state, because they do the work. They are providing all of these services. They are who's making this infographic happen. And we are very pleased of what our providers are doing and how this program has grown. Next slide. If you are in any of our meetings or join us for anything, you know that I've deemed this our 8-ball year. If you play pool, you know, if you hit the 8 ball, you have won the game. And I think it's time for us to really show how much the Apex program has won the game in our communities and really connect with our families and connect with our schools and are able to provide an opportunity for many individuals that may have never seen it. I will pause right now. I think we're going to play a little bit so that you can understand just how impactful the Georgia Apex program is.
We are seeing increasing numbers of children that are coming to school with mental health concerns. Many of them are bringing some societal issues with them. They're bringing issues that are happening within their families. And what we're seeing is that the children are not able to—
I can't hear it, Ann. Can you turn the volume up?
with them, either emotionally, behaviorally, or in the home.
The APEX program is a school-based mental health program to provide mental health.
See if I can turn the volume up. It's not letting me go to my volume, and it's up as far as it'll go.
Okay, I'll just lean closer to the
I'm
computer.
sorry. I have it optimized for sound, but let's
That's
see.
okay.
Okay.
Health services in the local school systems.
We are in partnership with the DeKalb Community Service Board to offer the APEX program to several of our schools.
So we actually have therapists that are housed in the school settings to provide mental health services to the students and also their families.
The students are able to receive individual, group, family counseling here at the school.
So with the funding that comes with this grant, we are able to see that our students are getting the necessary services that they need. It also benefits our families because many of the families are not able to take off during the day, come and get their children and take them to see a therapist.
I am connected with their therapists who are usually in the schools, can really get an idea of, hey, this is what's going on in the classroom with this child. They're seeing the child in really two different areas. They're seeing them in their room, so one-on-one, but they also get to see them kind of in a group setting when they are challenged or expected to do certain things in a structured environment. So having the therapist kind of give the family a little bit more information than maybe if they were only in the office is extremely helpful.
They just kept suspending my son and kept suspending him, and I'm like, he's been home more than he's been in school. Something is wrong. I mean, can somebody help me? So we started receiving services as of January this year, and everything is done a complete 360. He knows how to express his feelings. Like, instead of just saying I'm mad, he's gonna tell me why he's mad. It's just bringing a better understanding between both of us, better communication.
A child who's experiencing mental health issues, experiencing trauma, really has difficulty concentrating in the classroom.
He just didn't have a good outlet of how to channel his emotions and his anger and things like that. So it was really disrupting his schoolwork because he's so bright, but if you're constantly running out of the classroom and constantly crying, he was doing the same thing at home. As a mom, you try to do it on your own, you just try to look for root issues. I need help figuring out what it is, and if it wasn't for this program, I probably would still be running with my head cut off. I may not know where to do, but I know where to go with people who do know what to do. So it's like a breath of fresh air. I think a weight has been lifted off of his shoulders. It's a lighter load for him, and I could just tell he seems free. He does.
I think of the classroom for kids as really, again, where they spend most of their time. That's like their job, right? So it really gives us an idea and kind of a litmus of how they're doing. Because if they're not doing well in school, maybe something's going on at home, maybe something going on in their social group. So having that connection to the classroom and what's going on in school really helps, because I don't have that with kids who aren't in the APEX program. So that really helps me tremendously when I'm thinking about treatment options and kind of where to go.
In the summertime, not having a structured day program, going to school every day, provides challenges, especially for children that have behavioral and emotional issues, because they can backtrack over the summertime. We have been very fortunate that one of our board members, Meredith McCoy, has provided us funding for our APEX summer camp program.
These kids that are in the APEX program, they do not have the means to go to camps. And so by this program being available to them, not only are they getting a wonderful experience, but they're getting this experience delivered to them by mental health professionals.
In the summer camp, in addition to still receiving individual and group services, they're also continuing to receive their educational services. We partner with the school to provide a teacher who can provide continued education services. And then, of course, camp is about having fun too, so we offer a lot of fun activities here at the school, as well as going out in the community.
It really does allow children who normally wouldn't be able to attend summer camp because of their behaviors have a place to come where they are still allowed to be themselves, but then still get the therapeutic services that they get throughout the school year.
She didn't have any kind of communication skills, but now she has improved quite a bit. She comes home from the program happy, bouncing around. It's great. Sanaya has been diagnosed from a psychologist of having pragmatic social communication disorder and anxiety. So she has benefited a great deal because she interacts more with her peers. Each day she comes home, I will ask her how was her day, and she will say great. And there will be this smile, and then she come home, she got me engaged in what she did and what happened in the program. And she's, to me, that helped her with communication and sociable. She's very sociable, especially with people in this program. So I think that was positive for her.
So from a financial standpoint,
Okay, go ahead, Layla.
So as you heard in the video, there are many partners or many players at the school that really intertwine with each other to make sure that those in the school who need these services and can meet the criteria to receive these services, receive these services. We work with the school social workers, we work with school counselors. As we know, school counselors' main objective is around academics, but they deal a lot with social and emotional, and this is another way for them to refer so that they can focus on what they need to. Social workers, their caseloads are out of the water, so we know the many needs that social workers may have, as well as teachers. We know that teachers are there to teach, but they get many children that come into their classrooms that are dealing with trauma, mental health challenges, families who have gone through things, communities who have gone through things. As we know, the world right now is a whole traumatic experience for us all, dealing with COVID and dealing with many other things that are happening in the world. So we know that the Georgia Apex program provides that opportunity for them to have that immediate connection with families. But not only are we connecting children with services, we're also providing opportunities for our clinicians and individuals who are working on becoming clinicians to become interns. So that's what I want to talk about now is our Apex internship program. We know that there's a huge workforce shortage across the state with 988 coming out and having the many of what I have learned is 56% of 911 calls are mental health needed calls. So now we know that 988 is out there and many of those calls will be rerouted, but are there enough people in the community to really connect those individuals with? After dealing with the crisis, how do we connect them with long-term help? How do we connect them to make sure that who we're training and who we are employing here in the state are staying here in the state? Retaining our workforce is really been a challenge for us at the Apex program, but the internship program is a new way to address that workforce shortage. We provide additional trainings to our school for school-based services. We are putting them in the environment of where they'll be working in so that they are being able to train in that environment. We know that providing school-based health services is much different than providing services in a provider setting. We know that clinicians need to know how to work within the school building, know how to have and be able to refer back out into the community for other resources and supports, being able to provide support at that universal tier 1. The Georgia Apex program provides services across tier 1 to tier 3. We are just not in tier 3. We are doing those classroom observations. We are going to events. We are going to PTA meetings. Our clinicians are on the call for crisis calls. So we are doing a lot when many other providers are just providing that tier 3 services. Our social workers, our licensed or other mental health counseling students are able to participate in this Apex internship program. It's agency-based, so many of our agencies are housing these interns and really being able to hold them in those communities where they're going to school and be able to work and learn through this internship program in hopes of being employed by that provider. So now we're growing our workforce and we have a pipeline from the internship program to our mental health providers. We are looking for support to help recruit and retain interns. As we all know, this is a challenge for us, and we are always willing to partner with individuals to help grow our workforce shortage, and thinking outside of the box on how do we educate and inform others to be able to recognize signs and symptoms, to be able to refer to other programs. Integrated mental health, integrated health services, working with our clinicians, working with our primary care providers, working with our nurse practitioners. As we know, many of our communities do not have a pediatrician or do not have a school-based health center or do not have a social worker to be able to funnel these children. So how do we inform, educate, and train other individuals in that community to be able to provide those services? So I'll shift it to Ann now to continue.
Thanks, Layla. I just want to spend a few minutes talking about a study that we did. We wanted to also be able to rigorously evaluate the Georgia Apex program and look at its potential impact on overall school climate, which we know is incredibly important for student learning, for what's happening in the school, as well as for child and adolescent mental health. And so what we were able to do is we weren't able to randomize because things were already out in the field. We were able to use a method called propensity score matching. And what we were able to do is take a set of schools that had the Apex program and match them with schools that were not participating in Apex. We matched on things like percentage receiving free or reduced price lunch, school type and size, rural status, whether or not they had positive behavioral interventions and supports. And we examined change in school climate indicators over a 4-year period from 2015 to 2019. And we chose 4 years of implementation also because we wanted enough time to allow partnerships and programs to develop. School climate was measured annually through various surveys administered by the Department of Education, included parent and student survey data, attendance, discipline, safe and substance-free environment, the presence of PBIS, and a higher score was a more positive school climate. And in these next 2 slides, overall, we did see that schools that were participating in Apex had a significantly greater increase in overall school climate over time. This slide shows a very specific indicator of school climate, the mean student discipline rate. Higher scores actually are more positive student behavior and fewer disciplinary incidents, so it's a little bit counterintuitive. But what you see here is that those schools participating in the Apex program did have a significantly greater increase over time of more positive student behavior, and that means student discipline rate. And we saw a similar result for mean student attendance rate. Those schools that participated in the Apex program had a significantly greater increase in the mean student attendance rate over time than those not participating in Apex. At the end, they were not necessarily significantly different, but based on where they started, there was a significantly greater increase for the Apex schools. So what I want to do, I realize that we're kind of running over and short on time. I want to spend a few minutes really focusing on the importance of mental health promotion and prevention initiatives and building resilience within the school setting. With our rise in mental health problems, among children, young adults, and families, the research really does show the importance of identifying and providing tools early on. So the prevention and the promotion initiatives can enhance awareness around mental health, can identify risk and protective factors, decrease mental health stigma. And we know from the research that early intervention can positively change mental health trajectories for youth, and that resilience, coping mechanisms, tools, protective factors can definitely protect against adversity. Some of the factors in the research that we know are associated with resilience in youth. One of the single most common factor for children who develop resilience is at least having one stable and committed relationship with a supportive parent, caregiver, or other adult. So that's social support and strong relationships. Providing experiences for youth, for children and youth that promote productive decision-making, engaging in activities, youth voice, development of adaptive skills, helping them find sources of faith, hope, engaging in their cultural traditions, and health promoting activities like physical activities, stress reduction practices, programs that build executive functioning and self-regulation skills. So in this next slide, I just want to give you some examples of prevention initiatives that we have here in schools in Georgia and also nationally. We've talked about PBIS. PBIS is in over 1,400 schools within the state. And again, that has been shown to be strongly associated with positive school climate. Sources of strength and mental health first aid are both training programs that address suicide, violence, and bullying with sources of strength. And mental health first aid is like a CPR for mental health. It's really a skill-based training course that teaches participants about mental health and substance use issues, teaches folks to ask questions like what happened instead of what's wrong with you, really building awareness around mental health. And there is a newer teen mental health first aid that actually trains the teens to work with each other and with their peers as well. Mindful Schools provides training on mindfulness for children, for teachers, for staff within the schools. Project AWARE stands for Advancing Wellness and Resiliency in Education. This is a grant that is provided through SAMHSA to, again, partner between the education agencies as well as mental health agencies to build efforts within the schools around mental health. Georgia had an AWARE grant in 2014 in Griffin, Spalding, and Muskogee and Newton County schools. And currently in 2020, they were awarded to do work in Bibb County and Hall County. Georgia is also a leader in peer-led efforts. We have a strong certified peer specialist program. And Layla has mentioned that within the APEX program, some of these schools have also been integrating certified peer specialists as part of that as well. And then the research also suggests that engaging in physical activity in some way also is associated with decreased symptoms of depression and anxiety. These are just some additional resources for working with children and families. The National Child Traumatic Stress Network has a nice page and document that really talks about how to work with parents and providers around developing resilience. On the right is an excellent academic article that really talks about post-traumatic growth among children, post-traumatic growth being a step beyond resilience, working with children, working with adults to be able to work through adversity to a point where they develop or grow in some new way, new relationships and new activity. We had some children that we asked post or following some of the pandemic, what they may have learned or grown, and some examples were learning to play the piano or developing some new relationships. So this article is very interesting. This is another resource that's put out by the Yale Child Study Center to work with kids to help them to be able to identify their feelings, to know what to do with feelings. Strong for Life also has some documents that are available for helping kids to identify and work with their feelings. They're available in Spanish as well as in English. Layla, you want to talk for a moment about Free Your Feels?
Just a moment. I know we're short on time. So Free Your Feels is a mental health awareness campaign that DBHCD and Voices for Georgia's Children partnered to create during the pandemic. As we saw the need for it, we saw the need to provide resources to families, caregivers, children, as well as teachers and admin during that time. I will drop the link in the chat.
Awesome. And I think we will share copies of these slides. The links are also in these slides, so you can go to some of these documents and some of these materials to learn a little bit more. And finally, these are also 2 additional initiatives and programs within Georgia, Resilient Teens and Raising Resilience, that both really focus on helping to build resilience. The one on the left focused on teens, working with Augusta medical students, working with the teens in an online platform, and Raising Resilience are a lot of materials and documents that help parents to engage in activities to build resilience, and they have materials from infancy all the way up to the teenage years. And so we are in a time of a lot of challenges, as we've been talking about, but we also are in a time of opportunity. And so Layla and I would just like to end by sharing a few thoughts around opportunities that we think would be helpful to consider here in Georgia. We've talked a lot about the importance of prevention, and so exploring funding opportunities for prevention initiatives within the school setting, providing training and the necessary infrastructure, looking for more consistent financing opportunities for those services which often aren't billable, but which are incredibly important in terms of having that full pyramid. Expanding youth-informed and youth-led mental health initiatives in more of Georgia's schools, like teen mental health first aid, like engaging more certified peer specialists within the school-based mental health programs. We've also heard that one of the difficulties for some social workers and counselors within the schools and within the agencies are some of the barriers to obtaining licensure. So the cost of the exam, the materials, the actual license, the cost and availability of supervision. And so I think if we can identify and look for ways to decrease some of those barriers for licensing, we will also be helping to increase the workforce, and we will be increasing people who are able to provide those services as well as supervision, so it can help with the cycle. It was great to hear Lynette mention the Certified Community Behavioral Health Clinic model, because we are aware of the recent influx of funding nationally as well as here in Georgia. And so that may be a model that would be helpful to consider also to expand and support school-based mental health programs throughout the state, as it's a very integrated model. And lastly, thinking about, Layla mentioned that working in a school setting as a therapist is different, very different than working in an outpatient or an inpatient or hospital setting. And so really promoting training programs to prepare students and therapists for working in that school setting, providing training on specific therapy modalities like trauma-aware schools that the National Child Traumatic Stress Network provides. So these are just some examples of things that may be helpful to consider in Georgia for continuing to promote school-based mental health services. And we'll end there. We appreciate your time. I'm sorry you guys couldn't hear the video very well, but the link is also in the slides that we're providing. And please feel free to reach out to either of us, and we're happy to answer any questions.
Ann and Layla, Ann, you mentioned the 3 models. And I think I may have asked you this question, and I apologize if I'm asking it again, but between the 2 of you, between the APEX program and those other models, all the models, is there any way to find out how many schools actually have a therapist in the school presently?
So you did ask me that, Dr. McGivney, and we followed up on that. We do know, Layla mentioned 739 schools with APEX. We know that there are also 104 schools in Georgia that have school-based health centers, and around 41 of those also have the APEX program. What we don't know yet, and there is a work group with the interagency directors team that's trying to look into this to establish because there are other programs that are out there that may not fit into those two models, to try to get a better answer to your question. But right now, we don't know, aside from those two different models, what else is happening in Georgia. And Layla, I don't know if you want to add anything to that.
No, I just know that there were many of our providers that were providing school-based mental health services before the Georgia Apex program. So who and where and how many there are out there, again, there is a need to know, but there's going to have to be a huge landscape analysis that connects everybody, the providers, the schools, the clinicians, as we know that there might be some private clinicians that are out there. So some type of landscape analysis that the state can do to see where everyone is, see where the gaps are, and see how we can work together to better fill gaps and to support programs where they are. But I don't think any other program does evaluation like the Georgia Apex program for us to know where the schools are. Like, we have ours down to per provider, the staff that's included with our providers. So I don't know if anyone goes in depth as we do, but there can be a landscape analysis, but I don't think we have those numbers handy right now.
What is the relationship between the Apex therapists and the CSBs?
So they work for the CSBs.
They work for the local, okay.
Yeah.
So how many CSBs do you think are represented with the number of 700 plus Apex therapists?
Like how many CSBs are providing, like what's the number of schools? I do not have that percentage. I do know that all CSBs are a part of the Georgia Apex program, but we can get the number of schools that are the CSBs cover to you with a list easily. I just don't have that number handy right now.
Is the, and just a couple more questions. Thanks for bearing with me. Is the primary, we have 2,400 plus schools in Georgia. Is the primary barrier to having more therapists, more Apex, is it the workforce shortage, or is it funding, or a combination of both?
I think it's a combination of both. Workforce definitely oversees funding. I think there's a lot of funding out there that can be used and connected, but of course there's never enough funding. We don't pay our clinicians, I don't think, enough to be able to be providing services. So there's funding that can be used in different ways to incentivize and retain our workforce and build our workforce and connect different workforces into this school-based work. But I also think that the workforce shortage here in Georgia is nationally. It's not just Georgia that's dealing with it. It's all over the world. Many of our clinicians that have been here years are burned out. Many of those who come into this don't understand the work that they're coming into and the true need that is happening, not only here in Georgia, but across the world. So if we get in early and understand, if we get to our universities and colleges early to really inform and educate clinicians, and we get to our high schools early to build pipelines from high school to colleges to be able to fund our workforce, I think we think outside of the box when we talk about workforce shortage. There's a way that we can sort of put a Band-Aid on it now, but what do we do? What happens 5 years, 10 years down the road when people age out of who's servicing our children right now?
And Layla, in the internship program that you have, that's a great idea. Is that showing or illustrating to social workers and school counselors how they can become an LPC?
It's not down to that. We are in the beginning, like we're in the first year, but we are looking at ways and how to educate this to other clinicians and being able to expand it outside of where we are right now. But this is our first year, and I don't even think we're at the end of a full year. So it's the beginning of us, and we'll have more data to be able to answer more questions. But we can easily interview some interns or ask some providers of how it's going right now and where do they see it going. But right now we don't have the numbers to show that. This is something, funding came down and being provided through some federal funding, and we grabbed at the opportunity to be able to help fuel our workforce.
And one last
do we
question.
know? Oh, I'm sorry.
No, go ahead.
No, I just wanted to know if we know how Georgia's financial investment with our state dollars compares to other states' investment in a similar
In
In
school,
the
school program.
in the
school-based mental
internship program or the school-based mental health
the
program.
school-based mental health program.
And you want to speak to that and our partners in South Carolina, or?
Well, I think that the investment that Georgia has made has been significant. I do think that South Carolina is another state where they have really invested money to build up school-based mental health programs. But I think Georgia is right up there. We could probably easily do a scan to take a look at those states that have school-based mental health and how much money may have been invested. But I know that this has been going on for almost 7 years. It started out much smaller and has grown tremendously. And we've learned a lot from our South Carolina partners as well.
Great
question.
We started
Good
off.
to know.
We started off in 100 schools. We're now in 738 schools in 7 years. So just to see the growth of that happening and how it has been welcomed by many communities and begged for by other communities. I sit on the Southeast South Carolina Conference for School-Based Mental Health. It's a conference that happens every April. I will make sure that you guys are invited to that. You can learn a lot about what's happening in South Carolina and other places, but I reach out to some partners and try to see if we have some information. I do know that we are eons ahead of everyone else. Everybody is always asking us where and how did we get here? And it's, just by the connections that we have made and how our providers are really, really working locally. As we know, each school district is locally controlled. Getting and educating our school board is important so that they know what is out there. They know what works so that they are able to inform their schools and school districts of what can be happening right there at home. So Georgia is definitely leading the map, but we will make sure to get those numbers back to you.
So when I first heard about Apex, I thought, wow, that's a really ambitious name because it's the top of the pyramid. But from what I've heard today, you clearly have earned that title, and I'm very, very excited about it and excited to have learned what I've learned today and want to ask more questions down the road and learn more about it. So clearly this is a great use of money and a way to bring mental health treatment into the schools where they're direly needed.
Thank you. Thank you.
And please feel free to reach out if you all have questions down the line, if anything jumps out.
Please do. My name is on the bus somewhere, so just find it.
Thank
well,
you.
This has been a wonderful meeting. Every one we've had so far has been eye-opening and rewarding and great use of our time. We've actually done better today keeping within our time limit than we've done in the past. So we'll work on our next meeting to do even better. But again, thank you all for you who participated and helped enlighten us in the challenges of child mental health here in Georgia. And hopefully we'll see you in November.
Thank you.
Are there any other questions before we sign off? Well, again, thank you all for being here, and it's been a privilege for me.
Thank you guys for having me.
Thank you.
Have a great day.
Bye-bye.
Have a good evening.